Good morning, everyone. As we come together this morning to collectively try and figure out the best way that we can push the needle forward in terms of developing quality measures to increase performance and outcomes from in-hospital resuscitation, I thought that it may be helpful for us to understand the current state of what exists. There are really only two organizations that provide any guidance, standard, or quality measure for helping hospitals improve their process and hence their outcomes. One is the Joint Commission, the other is the American Heart Association. The Joint Commission provides standards for hospitals, and the standards state that resuscitation services must be available throughout the hospital, that people must be trained and equipment must be available, and that hospitals collect data to monitor its performance. As you can see, these standards are quite vague and really don't provide any meaningful guidance or, more importantly, mandate, because that is often the only things that hospitals respond to, as to how to provide best quality performance of resuscitation services and then improve outcomes. The Joint Commission does not currently have any quality measures that look at performance in the hospital. They tried to pilot some quality measures several years ago and ran into several obstacles, which we will talk about through this presentation, that made them feel that at this point they could not forward those measures to the NQF for adoption and implementation. The American Heart Association helps hospitals try and push their performance to a higher level by providing guidelines for resuscitation and by the use of data from Get With the Guidelines resuscitation program. The Get With the Guidelines identifies performance measures of best clinical practice of the highest performing hospitals and tries to help other hospitals come up to that level, and also provides reward badges for performance based on outcomes and other types of performance measures. But participation in this is entirely voluntary. So what you get with this association is that you have hospitals that are trying to perform better because they want to. There is nothing that actually mandates them to do so. So there's very little impetus for hospitals to change the way that they perform resuscitation practices or to strive for better outcomes because the mandatory bar is set quite low. What can we do to help change things? Well, if you look at the way resuscitation happens in the hospital, it's a continuum. And what I would suggest is that we start to consider maybe, rather than having one big, huge, perfect outcome measure, such as neurologically intact survival to hospital discharge, maybe we should begin to think of interim performance and outcome measures that happen along the entire process of resuscitation. So you can very easily categorize the process and sequence of resuscitation events in the hospital, the first being prevention. The best way to improve outcomes from a cardiac arrest is to prevent it from happening in the first place. We'll see data in a bit that identifies the fact that many patients that arrest in the hospital have very abnormal vital signs for a period of hours before that event happened that go unrecognized and untreated. Perhaps that might be something that we would want to request that hospitals look at and monitor as a way to try and not have failure to rescue. Team composition, training, and skills retention. The current standard merely states that hospitals must have a team that responds to these people and that those people be trained. But the questions that we need to begin to ask ourselves are, what is the appropriate team? Not only what training have they had as checking a box that they completed a course, but the real important factor is what is their skill level and how do they retain that skill level over a time for something that they may only do once or twice a year, because that's really what happens at the bedside. So we tend in hospitals to have people that respond to a cardiac arrest event from many different areas that are a responder du jour. And they don't work together as a team, and they may be coming together as a team for the very first time to act with very time-dependent critical interventions. And do we need to look at that team composition and skill training and consider some source of crew resource management training? Would that be helpful to improve the process of resuscitation? Resuscitation performance itself during the resuscitation event is extremely important, and there are many targetable areas within this section. Equipment is supposed to be readily available. But what we really need to ask ourselves is, are we using that equipment to its optimal benefit? There's a defibrillator that sits on top of every code cart, and yes, it will perform defibrillation, but nowadays it will also tell us the rate and the depth of the chest compression. It will tell us if we're hyperventilating the patient, and many of them will tell us if we can measure end-tidal CO2 to measure the physiologic effect of the quality of our CPR. All of those things have been associated with outcomes in cardiac arrest. We have that data at our fingertips, yet no one is really telling hospitals that they need to use that and measure it. Post-arrest care probably has the least amount of data because it is a new area in cardiac arrest, but there are clearly areas such as timing for withdrawal of life support and EEG monitoring that could be targeted. We know that there are many, many errors that happen in cardiac arrest in the hospital. We looked at over 118,000 patients in hospital cardiac arrest and identified the fact that errors are common. And when they happen, there's an increased likelihood of lack of return of spontaneous circulation and death before 24 hours, and that's survival. And as a matter of fact, if you have an error that happens from a shockable rhythm, your chance of dying is 34% higher than if no error happened during that cardiac arrest. We also looked at something as simple as documentation of end-tidal endotracheal tube placement, and found that in 1 in 5 patients, that was not documented at all in the record. Now, that either represents lack of documentation or poor clinical practice, either one of which is extremely targetable. Quarter of these patients were only documented by auscultation, which was in direct avoidance of a level 1 guideline that's out there. So there's plenty of opportunity here for us to look at interim performance measures. We know there's a great deal of variability in hospital performance, that hospitals with the highest proportion of patients that are unevaluated with abnormal vital signs have the lowest in hospital cardiac arrest survival. Case mixed and adjust cardiac arrest rates vary across hospitals, and they shouldn't. If you look at variations in both hospital and pediatric cardiac arrest, hospitals can have survival rates that range from 12.5% up to 23%. It shouldn't be a crapshoot as to what hospital you're in, whether or not you survive your arrest. And hospitals can make themselves better over improvement, but it's not even across the board. We also know that there are delayed times to self-reported defibrillation that impact outcomes, that survival is not the same on nights and weekends, suggesting that the process that we provide is not consistent 24 hours a day and 7 days a week. And that we also know that physiologic monitoring of CPR during in-hospital cardiac arrest can improve outcomes. But there is no guidance to tell hospitals that they should be doing any of these things. So keeping in mind that a quality measure is one that needs to be easily abstracted from a reliable source data and also be able to be risk adjusted when appropriate, it's easy to understand that there are many challenges for the development of quality standards for hospital resuscitation. Reliability of data is a very large issue. If the data going in isn't reliable, then the quality measure won't be accurate. And so there are issues such as time synchronization, which perhaps our industry sponsors can begin to help us with. If we have a measure that is totally dependent on time, the quality of that measure will be low if the time is not accurate. Risk adjustment is also an issue, and there are ways to adjust for hospital and patient confounding variables, but one large issue is that of DNR status. Perhaps we would want to consider making hospitals report all deaths by broken down, whether they were DNR or attempted resuscitation, so that we could risk adjust for hospitals that aggressively go after DNR status versus those that don't. In summary, what I would really like to leave you with today are a few key thoughts as we go into the breakout session. There is a great deal of variability in performance that is linked to outcomes in hospitals. It shouldn't be that way, and we can't let it stay that way. There is currently a lack of mandatory quality performance measures that either improve outcomes or hospital after resuscitation. And yet, from some of the data that I've just shown you in a few minutes, there are easily targetable areas across the entire spectrum of hospital resuscitation that could be targeted to develop interim quality performance outcomes that eventually could get us to the point where an accurate measurement of survival to discharge would be able to be obtained. There are clearly limitations in developing these quality measures, but they are challenges and they are not deal breakers. And the only thing that we can't afford to do is to do nothing. And if we leave here today without a clear sense of direction and commitment for improving the quality and outcomes of resuscitation in the hospital, then we failed the very people that most of us have spent our entire career trying to help. Thank you.